Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit OIEBroadcasting.com and sign up today.
Hi, this is Dr. Kerry Gelb, host of the documentary Open Your Eyes. Have your eyes ever felt like there was something in it? Did they ever feel sandy? Did they ever tear? Well, you may be suffering from dry eye. Today, we have a world expert in dry eye, ophthalmologist, Ph.D., Dr. Harvey Fishman. Dr. Harvey Fishman got his Ph.D. from the Department of Chemistry at Stanford in the area of lasers and neuroscience. He has his medical degree from Stanford, and he did his residency in ophthalmology at Stanford. He was awarded one of the first Stanford University BioX grants for his work on the artificial synapse chip. He's published over 30 research papers. He's an inventor. He's been on many TV shows. He has many famous patients. He's a great lecturer. I've heard him lecture many times, and he's also just a great guy. So, Dr. Fishman, thank you for joining us today.
Kerry, great to see you. Thank you so much for the invite. This is an incredibly exciting time for you with Open Your Eyes. I'm really excited about your upcoming film and everything that you're doing for the field. I mean, you're really, it's amazing how much you're contributing to people's knowledge and everything that you're doing. It's wonderful. I mean, this is truly what helping people and helping patients is about.
And we have some exciting news. We're starting a web show together. Tell us about that.
Yeah, we're doing this great web show. You know, you and I decided, we met a couple of years ago, we really hit it off, and we said, hey, let's do a show where we discuss basic eye disease, anything eye, everything eye, doesn't matter. It could be sunglasses, it could be, blue light toxicity or not, anything, circadian rhythm, how the eye works, pink eye. And all that stuff, we said, hey, why don't we do this in a web-based format that we can really explain, like we're talking to patients, like as opposed to like 2 doctor talks, which are exciting, and good for doctors, but there's nothing out there that where you have 2, very passionate and experienced experts in our own areas where we can really talk to the patients. And my patients all the time are always asking me, is there some place I can listen, to you or to understand more about what you're saying? And so this is like an opportunity for us to, with this web program, this web show called 4 Eyes. And here's my prop just to is it this kind of 4 eyes? Maybe. No, actually it's all 4 of us, all 4 of our eyes. But the reality is that we want to have something where we can really talk to somebody, like you're talking to your patient, like you're in your chair and you're with with patients in the chairs, you're talking to them, and that's what I'm excited about. It's going to be a lot of fun.
We have the full circle covered because I'm an optometrist and you're an ophthalmologist in addition to being a PhD. So we cover the whole circle. So sometimes we're kind of in our silos as an ophthalmologist and we just concentrate on one area, or as an optometrist, but together we kind of have all the bases covered.
That's right. And of course I'll throw in my little joke about having that PhD in physical chemistry. And I feel like and I got that first. So it's like I'm a physical chemist trapped in an ophthalmologist body. So we actually have the whole science aspect. So if you want to talk about quantum chemistry and physics and talk about how light interacts and single molecule detection, we can get into that too. But obviously that might be a little too much for people to stomach. They might think that's pretty bad and not fun.
Well, today we're going to talk about dry eyes. A number of years ago, on a serious note, for the Fox News fans out there, Shannon Bream, who's a Fox newscaster, if you ever heard of her, she almost committed suicide. She was in so much pain because from her eyes being in so much pain from being so dry. We would wake up, she would wake her up in the middle of the night. I mean, she might have had ABMD or some other things, but it would wake her up in the middle of the night, and she was in so much pain. Can you talk a little bit about the symptoms of dry eye and maybe the spectrum of symptoms?
Yeah, I mean, it's a great question. I mean, you know, dry eye is such an interesting disease because there are so many subtypes of it, Carrie. And one of the challenges of dry eye disease is that we really haven't done a good job of quantitatively like what different types of disease is with dry eye. And I think that the biggest problem is it's like, you know, a lot of dry eye disease, you know, it can be systemically driven, a lot of it. And like, for instance, you know, when you think about dry eye, I actually think about dry eye as the three-legged stool of dry eye. In fact, I have a poster in my office about that. You know, we talk about the three components of the aspects of your eye that keep you lubricated: the tears and the oil that come out of the eyelid margin, and then the eyelid margin, not only from the standpoint of the surface roughness of the eyelid margin, but also your blink and so forth, and your anatomy. And I mean, so dry eye can show up, to answer your question, dry eye can show up in so many different, the symptoms can show up in so many different ways. Like, you know, in a very dramatic case, like in some of the patients who have had refractive surgery, they can be, when you cut the corneal nerves, they can grow back in a very abnormal, aberrant way. And it can be like literally like having shards of glass in your eye every morning for the rest of your life. And that sort of neuropathic, they call that neuropathic or corneal neuropathy. That kind of pain is just excruciating. It's very similar to the kind of pain that you get with, you know, some of the phantom limb syndrome. So some of the soldiers and other people who've lost their limbs, and then they feel excruciating pain from their missing limb, even though there's nothing there. And that's because the nerves grew back incorrectly. And so with respect to that case you're talking about, a lot of the refractive LASIK and even some of the new patients with the new SMILE technique, you're not, you know, almost any kind of cut into the eye, it doesn't matter whether it's a, you know, refractive laser. It's mostly refractive laser surgery, but you can get it with anything. You can get it with all sorts of corneal injuries, and you can have it with pretty much any kind of an insult to the eye. But the thing is, this pain syndrome is extremely bad. It's like taking a micro needle and just stabbing you in the eye multiple times every day, continuously with no relief. And that's obviously the very, very bad example of dry eye. The vast majority of people with dry eye have like a little grittiness where they feel like a foreign body sensation, or they feel like something's there. And that's another type of, you know, form of dry eye. And then, you know, you can be burning. You can get burning sensation and that has to do with, at least in my perspective, about the salty, your tears can be kind of salty. It can be almost like going into the water, to the ocean, how your eyes burn when you get out of the ocean. Similar kind of symptoms. And then of course you can have other symptoms. Like if you can actually have symptoms that are like light sensitivity, where the only thing you have is light sensitivity from dry eye. And then the other thing that's really fascinating is that what was fascinating about dry eye, as I mentioned, there's so many different varieties of it, Carrie, and there's so many different subtypes. So it's very difficult, and often you'll have, you know, multiple versions of the same thing. So you can actually have, you know, you're not just limited to one, and it's such a complex variety of different anatomies and, you know, and body types that give you dry. So you can have all these different aspects of, but what's, you know, you can also have where they have no symptoms at all. So I talked about that one patient who has it's like having needles in your eye every day for the rest of your life. And then there are other patients who have exactly the same, you know, maybe their cornea looks exactly the same, but the cornea is not, that's my son in the background, apologize for that. But the cornea can have all the signs. As you look at the cornea, it looks like the signs, but in fact they have no symptoms. And the only symptom that they don't have no pain, they have nothing else. The only thing that they have actually is that their vision is decreased. And that's because of the cornea can be irregular. And so it's super interesting. It's super interesting like how the disease kind of unfolds.
Yeah, the cornea is the front part of the eye. Now, what percentage? How many people in the United States you think suffer from some form of dry eye?
You know, the numbers again. It's such a difficult number because there's a lot of dry eye that's undiagnosed, and then when dry eye is sometimes diagnosed, it's incorrectly diagnosed. Like that, they look at something that's not, it's not particularly well characterized. But I've read, and it also depends on the age group. So in people, let's just say people older the age of 30, for instance, 30 or 40, the number of people who have dry eye disease has been, categorized as anywhere between 10 to 40%. And it also depends on the region of the country you live in. It depends on your anatomy. I mean, there's all these different aspects. And even kids now are having more and more dry eye disease. But it's a fairly large chunk of our population. And as I said, it depends on, there's a whole severity. What's really fascinating, Carrie, is that high school kids who are in Accutane, about Accutane where they take it for acne. Hey, their face looks great, but they destroy the glands in their lid margin. And so you see a whole bunch of kids right now who are going to have a lifelong issue with dry eye disease. They don't know it because they don't have years and years of inflammation because of the lack of oils in their lids. But over time, they're going to get, they're going to have problems. So it's interesting because kids are starting to get dry eye. And then, of course, I hate to bring this up, but screen time is just a disaster. And a lot of that has to do with the blink, that people are so focused on their screens and they don't blink their eyes, or they have incomplete blinks. And you add that to the fact that maybe their oil production is slightly low. So it gets, as you can see, it gets very complex, but a large number, way over 5%. Sometimes some numbers have been as much as high as 40% of the population. And then as you get to different age groups, it can be very high. In the age group older than 60 or 70, it can be maybe 50% or more patients. And these numbers, as I said, they're just sort of general numbers. I can't cite specific papers on this because I've read papers where it's across the board.
So you mentioned LASIK before, and there's a possibility to have severe eye pain after LASIK. Most people do well with LASIK, but
Yes.
Those patients that are in severe eye pain, what could be done for them?
It's a real complex position that you're in because it's a combination of both pain. There's a lot of psychological, issues and emotional issues, and so you have to bring in a whole variety of people to work with people on that. One of the things to answer your question is that there can be a lot you can do with it. First of all, the most important thing is recognizing what you have. Because I'm not trying to be, if you're a busy refractive surgeon doing 20,000 cases a year or whatever, it's not one of these things that you're so busy that you may not hear the symptoms. So first, the most important thing is if you have to identify it, and where are you going, Carrie?
To shut off the printer.
There you go. But what happens is when you have when you have to identify it, and then when you identify that this person actually has, and one of the classic signs is what we call pain without stain. And there's this concept where when we put different chemical, different things in your eye, such as fluorescein, I'm saying things. We put, a drug in your eye called fluorescein. It's a molecule that stains the cornea. So people who have corneal disease or problems with their cornea, you often see the cornea will light up with this particular dye, fluorescein, as you know. And what's fascinating is that a lot of patients, so when you look at the cornea and you do all these objective tests, you see nothing, and they still have pain. And that's what this pain without stain concept comes in. But for these patients, you have to take a more holistic approach. you have to look at everything that's actually driving pain into their pain center. So in some respects, the center of their brain, this area called the trigeminal ganglion, and there's also thalamic areas in the thalamus in your brain, the thalamic structures. This is sort of this pain, center, sort of the super highway, sort of all these pain fibers from your face, your nose, your ears, your skin, and certainly your eyes, your eyelids, and your eye margins. All of these go, and your scalp, for instance, it all goes into the center part of your brain in this trigeminal ganglion area. And what happens, what we know from animal models, is that they actually reorganize. The nerves actually change their structures, and the connections really change their structures when you have a pain syndrome. And so it's very complex to sort of unravel that. You can work on it, and you can do it. One of the things I do in my practice is every aspect of potential pain fiber that goes into the center of your head, you have to minimize it. You have to treat it. So with a LASIK patient or a refractive surgery patient that has this pain syndrome, what I do in my practice is we use every single modality to reduce the nerve input into the brain. So we do things like serum tears. We do things like, obviously working on the microbiome of the gut through a variety of different diets, anti-inflammatory diets that we work with, that I work with patients on, and I work with other holistic doctors and naturopathic doctors who really specialize in that area. And then, there are specialized contact lenses, such as scleral contact lenses that you can use that reduces pain. We work with light and light sensitivity, and certain colors of light can set people off. And we work with different areas to try to minimize that. And then, I draw in other aspects of medicine. Like, for instance, we know that the acupuncture is a great way for some patients to treat some of their pain syndrome. And it's really a black box. I mean, a lot of the Chinese medicine that has evolved, really does work. But where it's not clear that we have the intellectual capacity at this point as scientists to really know what we're doing. But I'll draw in acupuncture. I'll have them do acupuncture. And then in addition to that, I will also draw in as I said, I work on the holistic side of the anti-inflammatory diet and the nutrition side to get people to improve that. And finally, one of the things that I find very, very helpful with these patients with corneal neuropathy is I think that just kind of teaching people and explaining to them what is going on, because there's a lot of anxiety, and that's a big part of why people have this. I mean, if you wake up with pain and you see like 4 or 5 cornea specialists and they say, well, here's some artificial tears, here's some restasis or lithidography, here's a little steroid, and that's it, and it doesn't work, they get very depressed and very anxious. And so I think a large and an extremely important part of working with people with dry eye disease is to really explain and teach them and show them what the mechanisms are. And I think that itself goes a long way towards undoing this. It's interesting, Carrie, a couple of years ago, when I was a medical student at Stanford, you have to go through all the different rotations, and I did a rotation in orthopedics. And one of the lecturers made a really good, he had done this interesting study on gunshot wounds. I don't know if I ever told you about this, but it's a pretty interesting study. They looked at gunshot wounds in different patients, and they found that if your gunshot wound was in the line of duty, if you were a policeman or an officer or whatever, and you were trying to, or military, and you were going to, and you got shot, and then they looked at patients who were in a robbery, or they were assaulted, or was in that, they were in a different situation. You can look at the exact same wound, and the patients who were in who were assaulted or trauma, they tended to have this pain syndrome, whereas the other people didn't. And so the psychological and how your brain interprets the pain is incredibly important. I mean, let's understand that the pain that comes into your brain from your eye, I mean, it's an interpretation. It's not, And I don't mean to say it's not real. It's like, I mean, then you get into this like existential discussion of what is real and what is existence and what is your, what are you, how do we perceive life? What are our perceptions of life? This is getting a little too heady for a podcast, but the reality is that like what is life and what is pain, excuse me, and when you think about it, it's just a perception of input coming into your brain, and you have to do what you can to sort of switch that. So that was a very long answer, but that's you have to look at this whole system holistically. It takes some time, but I've had a lot of patients who have had LASIK trauma and other trauma where we can get them to feel very comfortable. And and again, you may not. It's kind of like a bad back. You may always live with a bad back, but it may not inhibit your life. You know what I'm saying?
How do you compare this to like trigeminal neuralgia?
Very similar. Very similar. I mean, it's exactly the same mechanism. That's a great point. So when you talk about trigeminal neuralgia, it's the pain syndrome of the trigeminal ganglion. The trigeminal neuralgia, often you can get that from herpes, or you can get it from like, zoster, or you can get it from shingles, which is, where you get the bumps on your face. It's an outbreak of your previous chickenpox virus that then comes out. And you can also get it from, from jaw surgery, or you can have it from, you can have TMJ, for instance, that can cause it. But it's exactly the same concept, that you have this pain syndrome that's emanating, or that pain syndrome which is in the trigeminal ganglion, and and that is a very similar, great analogy to what happens to patients who have LASIK pain.
Patients sometimes go in for cosmetic surgery. They have a brow lift, and then they have an incomplete blink, and then it starts drying out. Can you talk a little bit about that?
Yeah, I have a lot of patients who've had that problem. In fact, I just had a patient, I would say worked with a patient about 6 months ago, and this patient had a blepharoplasty, lower and upper, and ended up, because of the surgery, and the surgery was fine. There was no complications of the surgery. It was perfectly good surgery. But what happened is that their blink mechanism really changed. And often what happens is I have a little wrinkle here. I don't know if you can see it. And I wish I didn't have these wrinkles. And if I had blepharoplasty, where I took out the extra skin there, I'm going to look better, but my lower lid might be a little retracted. And my upper lid, if I do an upper lid blepharoplasty, my upper lid may have a compromised blink. And what happens is a lot of the patients, it's not just a compromised blink during the day, which is called blink lag ophthalmos, but you can also have very significant blink overnight lag ophthalmos, where the eye is incompletely closed. You don't have a good seal. And the other thing that happens, and so what happens is it desiccates and dries out at night. But the other thing that's really fascinating, which I'm working on doing, I'm kind of doing like a little mini research area in my own office, which is the microenvironment of the eye, that there are different areas of the eye that, that can be affected, and it can really affect dry eye. So for instance, after blepharoplasty, you can get like swelling of the white part of the eye, the conjunctiva. And one of the things that I think is going on a lot with a lot of patients, and I think it's very it's not recognized particularly well, is this thing called conjunctiva chalasis, which is a little bit like, if you think about belly fat rolling, after you got a nice good rib dinner, like we shouldn't be doing, but if you're eating a big meal and you get a little heavy, and that fat kind of rolling over your belly, over your belt, they have that same kind of thing in your eye, where you have the conjunctiva kind of rolls over the lid. And there's been a lot of discussion about that
conjunctiva, the clear part over the white part, or when you pull down over here, the covering.
The clear part. When you get pink eye, what becomes pink, that kind of thing. And when that conjunctiva gets, what happens is that conjunctiva actually swells up, and that conjunctiva, that fleshy, clear stuff that's on your eye, is supposed to stay on the white part of the eye. It's not supposed to be separated. And what happens often in blepharoplasty is that conjunctiva actually separates and gets loose, and it could flop over your lid margin. And so what I think is going on, actually, a lot of times, it's not necessarily, there has been a lot of discussion that itself causes irritation and dry eye disease. I actually think that it's actually a what it does is it sterically hinders, meaning that it's forced, there's a little area underneath, right at the lid margin, where your tears collect. Now, if you have this fleshy, belly fat and rolling over your belt, it's pushing the tears out. Then at nighttime, there's no place for the tears to collect. And if you have a slight opening of your eyelid margin at night, then it's going to dry out. So that is a big problem that I see with blepharoplasty, is that the patients have this, they wake up and you can really clearly see it on the exam that you and I do. So that's, I think, a reason that people get this problem after cosmetic surgery. Now, again, that can be fixed. Now, interestingly enough, I actually saw, as I said, I had a patient, and I have a number of patients who've had that, and then ended up with the pain syndrome, just like the LASIK patients. So, you don't have to have LASIK to have that same pain syndrome, because if you irritate the eye enough, then you can set up this pain pathway, which we really don't understand particularly well. But when you set up this pain pathway that is that you have to undo. And remember, even if the cornea gets better, it's the central brain, it's the trigeminal ganglion that you have to undo that. You have to change those connections. You have to change those there's like synaptic and nerve remodeling that goes on in the brain, and you have to remodel. And that's really the job of what you do as a dry eye specialist in those patients, is that you work really hard with the patient to get them to get those pathways which have been set because of the pain syndrome. And you need to turn them back. You got to unwind it, so to speak.
So to go back to eyelid surgery,
Yeah.
a lot of people, as they're getting older, they don't like that their eyelid is drooping, or
Yeah.
they don't like the puffiness of the eyes, or they have the dermatochalasis where the top part is going over the inside
Right.
part. How do you decide, as a patient out there, decide if they're a good candidate to have eyelid surgery? Who's a good candidate? Who should they see for something like this?
Well, that's a great question. I mean, so there's sort of it's a spectrum. There are some patients who literally have so much dermatochalasis and so much hooding, the skin kind of droops, and it actually literally affects their visual field. And so, there's patients like that where it really affects your vision, because your eyes are not completely open. You don't get as much light in there. And the other thing that goes along with that often is brow ptosis. So not only do you have the lids get loose and kind of, extra skin, but the skin on your, the muscles that control that keep your brow up. And a lot of people not only get droopy eyelids, they get droopy brows. And so what often happens is that people use their brows to lift up their eyes, and they get in this state all day with their eyes kind of, in this kind of hyper tense state to try to see better. And so, you can get headaches from extra skin, above your eyes because of that tension and so forth. And so you can actually do, in our offices, as we can do visual fields, and we can do something where we take the lid and we tape it up. We do a visual field before and after taping, and then you can see what kind of improvement you get. And that's kind of like the medical standard of care. Now, I will say that it's very difficult to get insurance companies, and certainly Medicare, to even pay for that kind of stuff, because of what's going on in our insurance world. And we're definitely not going to get into that in this conversation. But just because they don't pay for it doesn't mean you don't need it. And so you can get a visual field, and if it does look like you have some extra skin there that's obscuring your vision and your visual field, you can get that's an indication. And of course, there are cosmetic reasons. I mean, when you have that extra skin, you look a little older, you look a little more sleepy, and you can, it's amazing actually, if you get a blepharoplasty, how that can really lighten up your appearance. You'd be surprised, you see patients and they say, hey, what did you do? You don't quite know what they did. Oh, I got a blepharoplasty. And then you're like, okay, you look better. So the reality is that could be very helpful. The type of surgeon, as an ophthalmologist, right, I'm very partial to ophthalmologists, a subspecialty of ophthalmology doing your surgery. There's an area of ophthalmology called oculoplastic surgery. So it's a special fellowship that ophthalmologists do after you become an ophthalmologist. Then you do an additional 2 years where you specialize in the eyeball and the eyelid. And the oculoplastic surgeons, are really specialized. And so, if you have an opportunity to see an oculoplastic surgeon, that would be my first choice for somebody having blepharoplasty. But, in terms of, and by the way, they're very good because they're ophthalmologists. They're very good at recognizing complications that may happen. And I'm not saying complications of the surgery. I'm not saying a surgical complication. I'm saying, you might get dry eye like we talked about after blepharoplasty. And if you have an ophthalmologist who is doing the surgery, then there's a good chance that it can be dealt with on a more timely basis. Now, the one thing but that's you're not limited. I mean, there are plastic surgeons who do blepharoplasties, and there are some excellent plastic surgeons who are not ophthalmologists who also, they really know what they're doing, and so plastic surgeons can do it. There are some ear, nose, and throat doctors, ENT, believe it or not. Some of them do reconstructive surgery around the face and the jaw and the nose, and they also do blepharoplasty. So those are the main groups that I would consider. I wouldn't, I think that, and of course there are some other people who, probably get into it, but I would focus, if you were a patient, to focus on first an oculoplastic surgeon with an ophthalmology residency, second, maybe plastics and ENT.
Since we're going down this rabbit hole with plastic surgery.
We are definitely going down a rabbit hole, but that's okay. But that's what this is all about. This is why it works. It works for us.
People sometimes use fillers for around their nose. There have been people that have actually gone blind from these fillers. Can you talk about that?
That's definitely a rabbit hole. But it's interesting. And totally cool.
I don't want anybody watching this going blind.
I know, absolutely. I mean, it's really awful because what happens is when you inject anything around the eye, you can actually inject into basically an artery, and you can get this artery. You can actually get this artery to connect to the back of your eye, to the ophthalmic nerve. So there are absolutely cases of especially fat. Like a lot of people put dermal fat in the skin around the face, and there have been quite a number of people blinded from fat injections. I've heard of blindness with the fillers, even non-fat, like collagen type fillers. People have gone blind because little tiny particulates actually retrograde in the vessels, get into an artery, and then actually essentially carry what to describe to our listeners, essentially a heart attack of the of the optic nerve or the eye. You can go blind because the blood supply that supplies the eye, parts of the eye, parts of the retina, parts of the optic nerve can actually have a clot in it. So it's like, can you have a clot in that, and then you go blind in those areas. Interestingly enough, that one of the things that I am very interested in my research in my office is the chalasia, styes. And there are a lot of doctors who actually will inject steroids into the eyelid margin to continue down this rabbit hole. But you can inject steroids into the eyelid margin to control the inflammation. And you can use, there's a steroid called Kenalog, or triamcinolone is another name for it. And this steroid actually has tiny little particles in it. And the idea is when you inject it into the lid, those particles sit there, and it's kind of like a depot, like a drug release system. It just sits in your lid or your face, whatever, and it lowers the inflammation. But those little particles can also go back and blind people. So when I have a patient who comes in with chalazion, styes, that kind of thing, I really try to get them not to do steroids. I do very little. I try to do as few steroid injections as possible, because this is a risk, and you don't want anybody going blind because they have a little stye on their eye. But you're right. Anything that you inject in the lids, around the eyes, your face. I've even heard of like a guy who had actually, you can do this technique where you put in serum, like PRGF or PRP, platelet-rich plasma. And I've even heard of injections in the plasma in the face that can cause blindness, because it, again, retrograde, goes back and then causes, I've actually seen also necrosis where they're holding all the skin. I've seen cases of necrosis where the skin basically becomes necrotic because a blood clot prevents the blood from supplying the blood to the forehead. And I've seen problems like that. So, unfortunately, everything we do in medicine can cause problems, and it's unfortunate. You have to, really I like to try to minimize, at least in my practice, I try to minimize those sorts of things. But in particular, I try to advise patients to do the safest thing they can. Unfortunately, the question is it safer to get a facelift? Is it safer from a risk standpoint to have a whole facelift and blepharoplasty as opposed to just getting an injection, like a filler or something? And the answer is, probably it's hard to know. I don't know if that study's ever been done, but it's certainly cheaper to get injections, and it seems like it's lower risk. And it probably, my gut feeling is it probably is lower risk for overall, but it still can cause problems.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Since you brought up styes, what can people do to prevent themselves from getting styes, or when the stye is no longer infected, it becomes a chalazion, which is kind of that hard cyst, that hard bump on the eye. Talk about what they can do to prevent it, and what happens when they get one. What should they do?
Well, also I'll take one step back, which to say is that styes, what a stye is a clogged gland, a clogged oil gland, and that clogged oil gland actually is the fact that you have clogged glands actually is part of dry eye disease. So that's very apropos to this conversation, because when you have dry eyes, often it is because the oil glands are not producing, or they're not delivering oil to the lid margin to help lubrication and so forth. And so so that's there's all these different types of styes where you can get like the lid margin itself can be irritating. In fact, I just posted, by the way, just as a little plug for my website, www.fishmanvision.com. I have a blog, and I often put on a lot, and also have a YouTube channel, Dr. Harv. I chat with Dr. Harv, and on my YouTube channel, I actually post really cool, with patient consent, of course, with no identified information on who the patient is. But I actually have videos of different things. I just did a chalazion. I did a hordeolum where I expressed it and I curetaged it. But in any case, and that's really a fun thing to watch if you get a chance. But what I was going to say is that the main thing about chalazion styes, which is fascinating, is because the oil glands in the lid margin are they're actually almost like, it's very much like a biosensor or a sensor for your overall health. And what I find is that the skin, just like when you break out, when you have a breakout on your skin, very much people have breakouts on the skin and they get a chalazion. And why do you break out on your skin? Well, it can be stress. Literally, it could be just having a lot of stress in your life. It can be, obviously, if the microbiome of your skin changes and you have all these issues with, like environmental dust and allergens. So what can happen is when that homeostasis, which is controlling the oils in your lid margin, kind of get off, then you can get this oils actually can, bacteria can get in there, but more importantly, the viscosity, how thick the oils are can change. And a lot of times that's systemic. So the answer to your question is that to prevent these things from occurring, it's sort of like healthy living. One thing is that some people are prone to styes, and so keeping the lid margin clean is extremely important. And we use all sorts of different products. Something as simple as like a washcloth with a little bit of soap on it, just clean off your lashes, and that can be something that can help. Although that can be irritating, soaps tend to be irritating, so they have more sophisticated products on the market where they're a little bit more pH friendly to the eye. My favorite, and I don't have any financial association with Avanova, but Avanova is actually one of my favorite forms. It's a very mild and pH balanced form of hypochlorous acid. You can get a lot of different types of hypochlorous acid, but eye drop or lid spray, but that one I find is the most mild for my patients. And then when you making sure that you're eating well can can definitely be an important, can be a very important aspect to try to keep them clean. The gut, often you'll have a blowout week in Vegas. I've never had one of those, but some people who do, actually I probably have at some point in my career, but you come back and they get styes, and is it because they're on a lot of dirty surfaces and they're touching their eyes, which you do a lot? That could be it. But could just be the overall, your immune function gets depleted. So it's a very complex problem. Once you get a sty, the really or hordeolum or a chalazion, whatever we call it, there are a couple different names for it. Actually have to do with where in the lid it gets, and which particular gland, which part of the gland, and the age of it. So that, again, I actually have I think on my YouTube channel, I discussed that a little bit. I'll probably do a blog on that because it's kind of nerdy and interesting to me. But once you get one, the sort of standard process is to melt the lard. One of my colleagues said, you got to melt the lard, Harvey. And the oils in the gland are just a form of oil. And if you can heat it and clean the lid, that sometimes goes away. That's a great way of getting rid of it. If it doesn't go away, one of the things you can do is there are, eye drops that we can use that actually reduce the inflammation. You can use a steroid eye drop, which I am not particularly psyched about doing in my practice. I tend to try to treat the underlying disease, which is usually it's like a little infection in the gland. The other thing is it could just be, you can get an eye drop, like a zithromycin eye drops that actually reduce the thickness of the oil secretion, and that's another way of treating it. One of the cool things I'm doing in my office is I'm doing a chalazion study with IPL, intense pulse light. So I'm actually running an IRB study. Well, it's all studies should be IRB, and my study is to look at using intense pulse light to treat chalazia and early hordeola. And intense pulse light is phenomenally interesting. And I know I came to all docs, we lectured on that. But the thing about chalazia is that with IPL, it's a non-pharmacologic and a non-incisional way of treating the chalazia, and that's really helpful. Not too many people do it because IPLs are not cheap, and it's an expensive procedure, but I think it's worth doing because of the fact that it can really get you into a much more comfortable and cosmetically good. You don't have to cut the glands, which is actually one of the things that we do. If it's sort of standard treatment is to, as I mentioned, either to inject with steroids, which I really hate, or you can just flip the lid, numb up the lid, flip the lid, incise the gland, and drain it like you're draining an abscess. And so that's how we treat it. I try to do. I'm really, as I'm getting more experience, not experience. I'm gonna say as I get older. I hate saying that, but as I get the further along I go in my career, the more I realize it's like less is more when it comes to medicine. If you can do less to achieve the same result, that's a better way of doing it. That's why I like IPL, but the price tag, which isn't cheap, is something that's a little bit an issue.
IPL, or intense pulse laser, how does that get rid of the sty?
So intense pulse light has a variety of different mechanisms that they propose is the mechanism. One is that we actually take that light guide and we actually are treating it, and it gets pretty hot internally. So it's a little bit like nuking it with a microwave. And so when you have a washcloth, you're not really able to heat it internally. But this thing is almost like internally heating that thing, that sty or chalazion, and it really starts to activate a lot of healing processes. Because of the fact that you're using light, there are these different you're actually stimulating the immune system to actually start reorganizing the tissue. And one of the problems with chalazion or sty is that you get scar tissue that forms in there around the oil. And one of the things that IPL, intense pulse light, is actually pretty good at is actually it can actually be used to reduce scars, even just skin scars on your skin, scars on your eyelid margin. And the scars, so there's some reorganization of the collagen that occurs. We know that actually when you hit the skin, when you treat the skin with these pulses of light, you actually stimulate collagen reorganization, and that is probably why it works to some extent. Now, the other thing that's interesting is when we do it, we use this protocol, the dry eye protocol, where I go along the lid margin like this, and actually even on the upper lid. And so one of the things that I just wrote a paper on, another little plug, is I just got a paper published on this critter called Demodex, which is a parasite that lives, and everybody has it in their lid margin. But IPL actually kills this parasite, so it reduces the population. And I know this is not about the microbiome. We'll eventually do a talk on it. I'm really excited to do that with you at some point. But the microbiome of your lid, of your skin, actually almost definitely changes when you do IPL. That could be why a lot of patients do better, because you're changing the intrinsic microbiome of the skin, the lashes, and then that also may contribute to an anti-inflammatory effect. So there's a lot of things that go into why IPL seems to be beneficial. Not only the direct heat that occurs, but the collagen reorganization, the immune system getting stimulated through a variety of different at the nuclear transcriptional level inside the cells, and the microbiome of the skin. So those are just a few concepts that may be very important for why IPL works. But it's a very cool technique, and I've just been very interested in it. As I said, we just had a paper that was published, and you can find that on my website as well, which actually shows the first time of a direct IPL, intense pulse light kill of a parasite. We actually show it where we actually pulse the light on the parasite. It kills it in like 4 or 5 pulses. Really neat stuff.
It's amazing how many people have these parasites living on their eyelashes, and they have no idea that they have them. I guess part of it could be part of the microbiome, but when it gets out of control, you could actually pull out an eyelash, put it under a microscope, and you see the critter with its mouth going, opening and closing and opening and closing. It's pretty crazy.
Yeah, I do that in my office, where I'll extract the lash and I'll show them under the microscope, and the patient, is both horrified and amused at the same time. But I think that one thing that's important for everybody to know is that we have the microbiome is so fascinating. I really truly believe the microbiome is going to be sort of the next frontier of medicine, and once we really understand it, which we don't. And I know this is not a microbiome talk, but just to say that, we live, there's something like hundreds of millions of different bacteria that live in our gut. There are, hundreds or, millions of different species that live on our skin and around our eyes. And it's both bacteria and viruses and parasites. And a lot of times, all these critters sort of live there. We're in sort of homeostatic, scenario. Like when oils get produced, you want some of those oils to be eaten up, and that's what some of these Demodex critters do. These parasites are actually helpful because it actually helps eat some of the excess oils off your lashes and your lid margin, and so you really do want these things. It's not like you don't want to sterilize all the parasites, but like everything, just like we talk about dysbiosis of the gut, where you have a ratio of good versus bad, bacteria that's in your colon. Same thing happens with your eyelashes. And so these critters are if they're too high in population, they actually can puke up inflammatory bacteria. It turns out these parasites actually have their own digestive tract, and they puke it up or they die. And actually the parasite itself, the cell wall and the cell components of the parasite itself are very inflammatory and can cause dry eye and various forms of dry eye disease. But so keeping them in the right proportion is really important. And that's very fascinating. Again, we're getting into different areas, but it's really exciting when you think about where it's exciting, because medicine is really it's always evolving, and we're just really scratching the surface of the microbiome. And as I said, there's such exciting research that's actually being pumped by NIH, the Human Microbiome Project, and the microbiome projects around the world. I mean, it really is the future, which actually full circle, which is another reason I got interested in dry eye disease, what we talked about initially, was that I was fascinated by, which I mentioned at the beginning of the podcast, was that, when some patients, not all, start taking fish oil, of course, you need to talk to your doctor before you do anything, to get that checked, make sure you're okay with taking fish oil. But if you take fish oil, there's a good portion who actually do better. And I hypothesized that that's actually, and I wrote a blog about this just recently, why is there this huge disparity between there's a double-blinded clinical study known as the DREAM study, which basically found that it was totally ineffective. It was a bunch of nonsense. And there are a lot of people out there who think fish oil is a bunch of nonsense for dry eye disease. But my theory is, and I'm actually going to hopefully do a clinical trial pretty soon on this, is that it shifts your microbiome, and we know absolutely the microbiome of the gut does have huge impact on dry eye disease, and we know that when you have a higher biodiversity of the gut, your dry eye patients tend to be less dry eye patients. And that was actually a study that a sort of a pilot study that I did and published an article in ARVO. I had a poster on that at the ARVO, the big meeting. And then there's, of course, some really famous dry eye people who've done it with really hardcore studies. There's a Nature paper, a science paper on this by some really famous, cornea specialists. But we know that the microbiome of the gut affects dry eye disease. And we know that, and a lot of clinical dry eye specialists like myself, have seen dramatic results with dry eye as a primary therapy. And so I suspect that that's the connection, but we need to really flesh that out. But it's really interesting because nutrition studies are notoriously difficult. And fish oil is just another, you're basically treating it with you're treating patients with food. And, and you have like very heated discussions. But, I think that the jury is definitely still out on that one.
Yeah, I think in the DREAM study, they were comparing olive oil against fish oil, and olive oil could be anti-inflammatory as well. So people did well in both parts in the olive oil group and in the fish oil group. And typically in dry eye, it's if you increase the EPA versus the DHA, the more EPA, the more anti-inflammatory type of reaction you get. And typically you get for dry eye, if the EPA to DHA is 3-to-1, and I think in the DREAM study it was only 2-to-1. So there are other studies on omega-3s that people actually do pretty well. But I want to ask you a question about that bug, that Demodex. If somebody has that, well, how do you treat that? Those bugs on your eye, those mites, how do you treat that, since we talked about it?
Right, so,
How do we get rid of those things? I don't want those things crawling on my eye.
I mean, I don't think that you need to, again, you don't want to get rid of all of them. You just want to lower the population. So it's really a titrate. You want to titrate the level so that it's not causing pathology. One of the things that's terrific is tea tree oil. I think that tea tree oil does a fantastic job at controlling it. And, it's not just using it.
How do you apply it on the eye? How do you recommend they apply it? And how do you do lid scrubs? How do you do lid scrubs?
Right. What I usually tell people is that, first of all, I recommend treating the face. It's like the smoking and non-smoking section back in the 70s. It's like the smoke drifts over. So you have, the Demodex often is on your face. So I always say that you start off with a tea tree oil facial scrub that works. And then you can get these special lid scrub versions of tea tree oil. And they can be pretty irritating to the eye. They don't hurt the eye. They're not damaging the eye, but they're very irritating. And so the way I explain it to people is that you take a little bit of the lid scrub and you kind of like drape it just below the lash margin on the bottom and the top of the lid without actually getting in your eye. And what happens is the tea tree oil actually will diffuse into the lashes and hopefully smother some of the Demodex. Now that's one way that I do it. You can also just keeping the lashes clean. It doesn't have to be Clearadex. It doesn't have to be like tea tree oil. Clearadex is the one I've traditionally used, but they haven't been. There are other versions that are also quite good. There are other, there are other brands. And again, I have no, I'm not wed to any one brand. But you can also use hypochlorous acid. Again, get back to what I mentioned before, and that's another thing that can keep keeping it. That basically that may or may not directly kill the Demodex, but it lowers the bacterial content of the lid margin.
And how do you recommend they use the hypochlorous acid or the Avenova?
Yeah, so the Avenova you can actually close your lid and spray it directly on your eye. Close your eye, spray it directly on your face, and then take it like one of the circular cotton discs that you get at the drugstore, and then just kind of rub it. I mean, that's the easiest way of doing it. You can also spray it on the little cotton disc, and then you can use that to apply that directly on the lid. Some people who are really good about cleaning their eyelashes, they can spray it on a cotton tip, and they can take a cotton tip and they can go along their lid margin. Obviously, you're closer to your eye when you do that. You have to be careful you don't give yourself a corneal scratch or anything like that. Wouldn't necessarily recommend that unless you're experienced and been trained how to do that appropriately. But that's how I usually recommend the tea tree oil, the hypochlorous acid, keeping the face clean, and then those are the best ways of really treating Demodex. There are some medicines you could use. For instance, you can take an oral medicine called ivermectin, which is a prescription medicine that gets rid of it. There's a lot of studies that show that as well. And actually some of the treatments that we do for rosacea, there's a huge rosacea Demodex connection, and treating facial rosacea also is a way of treating the Demodex. And so yeah.
Talk about rosacea, what it is, and how it relates to the eye.
Yeah, so rosacea is a vascularization. It's where you have these little they're called telangiectatic vessels, microvessels that get inflamed and cause inflammation and rosy. It's like you get rosy cheeks, you get rosy nose. I have some on my nose. It's generally it's not limited to people from Ireland and Northern Europe and so forth. You can have a large Asian population, they can get rosacea as well. But it's generally more fair-skinned people that get it, but not limited to that. And what happens is that when you have this on your face, it actually causes there to be, there does seem to be a connection between high levels of Demodex and high levels of rosacea. It seems that the blood vessels get inflamed, or they get super inflamed from the inflammation secondary to the Demodex. And so one of the ways that we treat one of the ways we treat rosacea was we treat it by using tea tree oil to get rid of the Demodex. And so that's a big part of treating. And actually, if you look at some of the more naturopathic treatments for rosacea, it always comes back to the gut. If you treat the gut, you can reduce, again, remember I mentioned the whole part about your face breaks out with rosacea, with different foods that you eat. So your rosacea we know 100%, rosacea breakout with alcohol or different foods you eat or spicy food. That is absolutely, we see that all the time. And so, really controlling the diet helps treat, treats the rosacea. And so that's sort of at the fundamental level. And then, obviously you can come into my office and other, offices where you can actually use, again, intense pulse light and other types of, there's also something called PDL, which is pulse dye laser. And that also can be used to treat rosacea. And there's Metrogel, which is metronidazole, which is another drug that can treat rosacea. And then there's, as I said, ivermectin and so forth. It's sort of this combination between Demodex and face and rosacea. It's very, very, very fascinating. Again, rosacea is not, we know it's an inflammatory condition of the skin. And by the way, full circle, people who have rosacea often get dry eye disease because the glands in their eyelid margin get, diseased and affected.
I think you make a great point because people that have rosacea, they're kind of not, one of the first things I look at is somebody's skin. And if they have rosacea, you know that their health isn't where it should be and that they need to work on their lifestyle, their diet. And you talk about that a lot. Tell us about how the eye could be a biomarker to your health.
Right. I mean, it's funny, Carrie, you should bring that up because as I get more, as I progress in my career, the more I see, about the more I see patients and the more experienced and more, experiences you have with patients, you really see how the eyes, that any kind of eye problem or any problem for that matter is often systemically driven. And so, for instance, there are some really interesting studies which show that patients with actually there was a paper that came out showed hyperlipidemia, meaning patients with high cholesterol levels or they actually have more glandular atrophy in the lid margin. So you can actually, so again, it's like using the meibomian gland measurements, and actually we do micrography, which is infrared imaging of the lid margin. You can actually see evidence of systemic disease in the eye. And then, and so to your point, that the eye really is a phenomenal organ to look at systemic disease. And then that's a whole nother, discussion, but it really is a biosensor for the rest of your body. I mean, your people often, as I said, will get styes and chalazion and dry eye secondary to systemic disease. Hypothyroidism, for instance, is often associated with dry eye disease. And, obviously some of the iatrogenic things that we do to our bodies, right, or that we do to our systemic health, like if you're on a blood pressure medicine and you dry the patient out, often that is we see dry eye disease, and that could be a signal that they're, for instance, too medicated. It could be that the medicine that you're using to lower the blood pressure is too extreme, and they get dry eye disease from that. It also can be, obviously a sign of allergies, and you can have allergies to anything. So it's fascinating how, if you really are a good clinician and you look at the eyes, you can make a lot of connections if you're really a good listener and a good observer. And I can tell you that's something that, we can all do better at, me included. But one of my goals for 2020, the year 2020, is to even listen better and to be a better listener and to be a better, observer of subtle signs in the eyes, and to then link that to systemic disease. But you're right; it's very fascinating, and obviously there's so many different aspects of dry eye and an ocular surface that's just totally very much connected to the systemic disease. Autoimmune disease. A lot of times people will get dry eye, and it's absolutely connected to autoimmune disease. It can be Sjogren's, it can be lupus, it can be a variety of different things. So you can see a lot of signs of systemic disease, and in particular, dry eye can be a very big biosensor, very telling biosensor for your systemic health.
You tell that great story how you saved somebody's life from being over medicated on blood pressure medicine, and it caused dry eye. Tell that story.
Yeah, I mean it's a really good story. It's very, internal medicine docs want to lower if you have a high blood pressure, there's sort of like a lot of them think lower is better, like as low as you can go. Okay. And obviously it's like the Goldilocks principle. You don't want it too hot. There's a porridge. You don't want it too hot. You don't want it too cold. You want it just right. And low blood pressure is not great because then you're also losing perfusion to your brain. And high blood pressure has the same problem. And by the way, low blood pressure, we're not talking about glaucoma, but the low blood pressure is a risk factor for glaucoma, and probably other neurodegenerative diseases of the body. But the story that I tell is like the patient comes in with very dry eye, and you talk to them. Why all of a sudden you have all these dry eye symptoms? And it turns out that their cardiologist or internist added additional medicine to their blood pressure regimen. That the doctor thought it was too high, So they gave them medicine, and now their blood pressure, there's so much, low blood pressure lowering medicine that their eyes dry out. But what we find out is that, and they haven't really mentioned is that when they get up really quickly, they get orthostatic hypotension, meaning that their blood pressure is so low that they get lightheaded too easy. So the conversation and the story is that, if they come in because of dry eye, you would inform the patient, hey, you're on this, maybe you need to go back to talk to your internist that you're over medicated, that your blood pressure is way too low. And that could actually save their life because, if an elderly person has the blood pressure too low and they get up too quickly or they get lightheaded, they can easily fall over and faint. That happens all the time. And now if you fall and you faint, you could hit your head, you could get a subdural hematoma, and you could die, or you could have a significant disability, or you could break your hip, and then that could be the beginning of really bad problems in your life. So it's interesting that by just hearing that somebody says, sometimes they'll say it kind of casually, because it's not like necessarily a big deal. They can say, I've noticed my eyes are a little drier. And if you're really smart, you go through the medicine list really carefully, and you find out that they're over medicated. So by telling them this, they go back to their internist, they adjust the medicine, and you could actually save their life. And it's a very small example of where the eyes really are a biosensor for the entire body.
So let's as we wrap up here, let's talk about the treatment for dry eye, and let's go through the spectrum of treatment. People with mild symptoms, and we don't see any autoimmune diseases, nothing very, very serious other than their eyes are a little bit dry. How would you treat that patient, looking for the cause of what the dry eye is, maybe some of the techniques you use to help diagnose it as well?
Right. I mean, I think that the biggest challenge in dry eye disease is really understanding what the etiology is. So it's like what you said, basically the first thing you have to figure out is like, why are their eyes dry? Why are they having symptoms? Is it the anatomy? Okay. Is it that they recently had a blepharoplasty and their lids are too low and then they have overnight dryness? So a lot of times just simply, suggesting overnight techniques to keep their eyes lubricated is important. Sometimes it has to do with they have rosacea, as we pointed out, and then Demodex, and they have like more of a conjunctivitis, and then you treat the Demodex, and that's the reason why their eyes are dry or irritated. Then, obviously correcting any sort of systemic medicine that might be taking. You have to look at the skin. Then you have to kind of look at the tear volume. One of the things that we do in my office is I look at the volume of tears using anterior segment optical coherence tomography, so I can very accurately measure how much tears. So if their tears are low, then you can use various techniques to increase it. Some people suggest you can use things like Restasis and drops that can increase tear production, or you can actually use punctal plugs. You can plug up the ducts with that, or with cautery, and that sometimes can be very helpful. There's a new device on the market called TrueTear, which is a nasal stimulator, and that can actually cause more lacrimal gland, tearing. So if it's too low in tears, those are some techniques you can use. If it's a oil problem where they're not producing enough oils and then their tears are very unstable, you can use a variety of different thermal pulsation techniques. I have a new device in my office from Alcon called iLux, and it will stimulate, it will heat and expresses the gland simultaneously. I also use another device called Thermoflow, which is a heating pad, a very precise heating pad that we put on the eyelids, and then I manually express it. Those are ways. LipiFlow is another one. There's a variety of different devices, and then of course there are, and those are different mechanisms. Sometimes the thing about drops, eye drops, I kind of feel, and I'm probably going to get assassinated by the pharmaceutical companies on this, Carrie, is that I do kind of feel that a lot of drops are kind of a patch. Restasis, lifidograph, steroids, you're basically cutting the inflammatory pathway, and it can be very helpful symptomatically, but you're not necessarily treating the underlying disorder. With that being said, I do think you need to use sometimes different drops that actually are anti-inflammatory. You really want to be very cautious about steroids, but you can use things like lifidograph, Restasis, which actually sort of cuts the inflammatory pathway. Remember that just because you're interfering with the inflammatory pathway in dry eye disease, you're not necessarily fixing the eye, you're just masking symptoms. So I think it's very important to work on lifestyle changes, diet, anatomy, those sorts of things. So the answer is that there's a lot that goes on to treat dry eye disease, and I think you need you need time. It's not something you can just rush somebody in and out for 10, 15 minutes in a chair. You got to spend time with them. You have to use a lot of devices. You can, and you have to put the whole picture together. So that's sort of how I approach it. It's not, it's not the easiest thing in the world because it's so complex. Everybody has different, types of anatomy and different genetics and different diet and different environments. And there's a whole bunch of different, things that go into figuring out exactly what their problem is. And on top of that, how to treat it. But if you do that, you can make, and you can sort of make the patient more comfortable, and you can hopefully prevent them from having lifelong problems.
You mentioned before about my biography to look at the glands in the eye to see if any of them have fallen out or any of them are twisted. You use OCT to look at the tear film. Is there any other special technology that you use?
I just bought a confocal microscope, so I actually can look at the corneal. Yeah, that's kind of a real heady thing.
You look at the nerves. Can you see the corneal nerves with that?
Yeah, you can see the corneal nerves. You can actually measure the meibomian gland orifices. That's something you could do. So there's a lot of techniques you can use to measure it. There's also you can measure with osmolality. You can measure the salt content. There's a nice test where you can actually measure what's called the matrix metalloproteinases, which are these MMP9, which are these inflammatory proteases that actually eats up tissue. And so if you measure that, you can see how much inflammation's in the eye. So those are some techniques you can. Obviously, good slit lamp exam where you use different dyes to stain parts of the eye. I actually also use high-speed videography in my office to look at blink dynamics. So those are some of the things you can do, and you just have to get a little picture.
Do you think people could really improve their blinking?
That's really fascinating. The answer is it's really hard. And I often tell people, I advise mindful blinking, and there are a bunch of apps, but the answer is very difficult. Sometimes if they have an exposure problem or they have a blink problem, you may have to, maybe like a special type of glass, glasses that actually blocks all the environment. Some of my patients basically say these things are hideous to wear. You can also go with like scleral lenses, special contact lenses that protect your corneas. So the answer is, I think my patients who have worked on mindful blinking do report back that it does help, but it's incredibly difficult because you need some reminders.
And people with that very severe dry eye and you use scleral lenses, how well do they work?
What
is a scleral lens, and how does it work, and how good does it work?
Yeah, so the scleral lens has been around for 20, 30 years. It was actually developed in Boston initially, or they popularized there. There's a whole clinic called the Pros Clinic in Boston site. What it is it's the old gas permeable lens, but they made it huge, and it actually vaults over. It doesn't even touch your cornea. It literally vaults over the entire eye. And there are these huge lenses, and you fill it up with fluid. So it's like your eye is filled all day with this fluid, this healthy fluid. And these lenses, when fit correctly and positioned correctly, it can be a lifesaver. I mean, they really are, in many cases, a very incredible option for severe dry eye disease. And the challenge is that, first of all, not everybody can put them in. The second challenge is that even when they seem to be fit correctly, they don't feel well to the patient. They don't feel comfortable. So because some people just don't like anything on their eye at all. So but for a subset of patients, where we do it in our office, and I use a lot of imaging devices, OCT, to look at the vault and how the cornea, how it vaults over the cornea and all these different things. And how it lands on the eye itself. Those things, if it's fit well, there's a huge number of my patients who do really well with them. But not all. Not everybody can put it in their eye. Not everybody feels comfortable with them. But in a certain group of patients, it is absolutely a life changer.
Well, I want to thank Dr. Harvey Fishman. He's a wealth of information. We covered a lot of ground. We did a lot of topics. And I really want to thank you for sharing your expertise. If someone wants to get in touch with you, wants to learn more about you, let us know about your new web show, Four Eyes, that we're doing together. Let us know about, again, your podcasts and your Google shows and your YouTube channel.
Yeah, well, thanks a lot, Kerry. This has been a lot of fun. I absolutely love hanging out with you. You are an inspiration to me, and I've really become much more interested in the holistic side of medicine because of you and our friendship. But to reach me, I have a fun website which I do a lot of updates on, www.fishmanvision.com. I have a YouTube channel called iChat with Dr. Harv. Where I post some of the videos of some of the lectures I've done. I also have a Twitter handle. It's at drfishman, one word, at drfishman. And I also have a Instagram channel called Fishman Vision. So those are different ways you can get to me. And I also do some telemedicine visits, especially if you're in California. And that's a lot of fun. And it's great. I mean, my goal, like yours, Kerry, is to not just treat patients in my office, but to try to educate people, because I can do and write papers and do these things that I can help people beyond just my own, tiny little Palo Alto office and sphere. But I really appreciate the invite, and you are a great guy. I am so excited about what you're doing with Open Your Eyes. I'm excited about, that is just a phenomenal film. But what you've done for vision and the world of optometry and ophthalmology is phenomenal. And then of course I'm super psyched about our upcoming video channel called Four Eyes, which is going to be a lot of fun, where we do a lot of fun videos and describe a lot of the stuff that we do. I think it's going to be a great time. 2020 is going to be a great year, and moving ahead, we're going to have a lot of fun educating people and helping people stamp out eye disease.
Well, thanks so much, Dr. Fishman.
Okay.
Thank you.
Take care. Bye.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. so many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe for You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe for You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe for You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe for You.
And most importantly, the reason why I buy Safe for You is because it's safe for me and you.